Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV 9.
Good morning. Welcome to Ethical Perspectives. My name is Pete Welch, and I'm the moderator for this morning's show. This morning, we'd like to have a segment that we've recently heard on the show 60 Minutes, entitled The Cost of Dying. With us first this morning is Karl Thomas, who is a clinical professor at the University of Iowa. Good morning, Karl.
Good morning.
And also with us is Amanda Sommerfeldt, who's the medical director of Hospice of Mercy.
Good morning, Amanda.
Okay. And finally, we have David Bullwinkle, who's a professor of philosophy here at Kirkwood College in Cedar Rapids. Thank you all for joining me this morning. In a 60 Minutes segment that was run last November, Medicare paid $50 billion in doctors and hospital bills during the last 2 months of patients' lives. That's more than the combined budgets, according to the information I got, of the Department of Homeland Security and the Department of Education. Doesn't that seem like a lot to be spending in the last 2 months of people's lives? Any thoughts?
I think that one of the things that strikes me is really how do we define things like value? So there's the money part of it, but what we're talking about really are people's lives. And so to start thinking about how much we should value that and how much we should pay for it, I think are really the fundamental questions underneath the observation that we're spending a lot of money for people who are in the hospital and near death. And as a society, we really do need to think a little bit about how much it costs and what the true value is of what we're doing in the hospital.
Would it be fair to say that if we were to take your term of value, then we would counterbalance that with, well, how do we balance on one end of the teeter-totter the value and the actual money expenditures, and then where on the other end of that same teeter-totter do we put quality of life? Isn't that always going to be an ethical dilemma in healthcare? Amanda, isn't that part of your role in hospice?
Absolutely, and I think certainly we spend a lot of money at the end of life, and we definitely spend more and we get more. We get more medications, we get more tests, we get more treatments, we get more doctor visits, we get more specialty consultations. What we don't see are better outcomes. We don't see patient satisfaction, we don't see people dying where they say they want to die, we don't see people comfortable with their symptoms managed. What we tend to see is a prolongation of dying rather than an extension of living, unfortunately, in a lot of cases.
And as a hospice person, there's as many different situations as you can possibly imagine based on, each person is a different dynamic in what they may want. Isn't that true?
Right, and it can be really challenging to try to match the available treatments to the patient and family goals of care. And I think that may be where some of the breakdown comes in, is that we haven't done a good job of matching those tests and those treatments and those specialty consultations and those medications to what patients and families really want at the end of life. And I think the other challenge is that there's a lot of uncertainty with prognostication. I think if we knew for sure that someone was in their final 2 months of life, we might react differently than when we're not sure. I think a lot of times the goal that someone might have is truly to try to get their loved one better. They may not realize that better isn't possible or isn't feasible. So I think a lot of times doctors, families, patients, they go through this thinking that they will come out the other side healthy or at least back to where they started before they got so sick. And unfortunately that doesn't always happen, but it can be hard to predict at times who is going to reach better and who isn't.
Dave, your thoughts on the dilemma
Yes.
of the services they're offering?
I was just thinking about what Amanda was saying and remarking to myself how strange that is, that in these days of evidence-based medicine, that prognostication is so difficult. It's a this is a complicated problem because we have to keep in mind the interests and the perspectives of a number of different parties, right? Of course, at the center of all of this is the patient and maybe their family, or proxies who may be helping them make decisions or making decisions on their behalf. And on the other side, we've got physicians who have to work with the best knowledge that they have, but are not really in a position to make decisions on behalf of patients, right? In order to respect patient rights and autonomy, it seems that physicians have to defer to patients whenever patients are able to make decisions themselves. And yet, in order to make good decisions, the patients need information from the doctors. It's a situation that, it seems to me, calls for a lot of good communication, and it's a kind of communication that's very difficult, given that it concerns the end of life, which is a topic that in our culture, and probably in many cultures, we tend to be very squeamish about discussing. It's not the easiest thing to discuss.
Now, one thing that, now I'm a private practice attorney here in Cedar Rapids, and I think that many times doctors, when they're describing something to either the patient or the patient's family, the doctors tend to be possibly worst case scenario in relaying that information. And then if the patient does anything better than worst case scenario, they tend to think of the doctor as being more godlike because the patient did better. And the other part of that is that they're afraid of possibly being sued if the doctor shoots a middle of the road analysis and then the patient gets worse, then they think it's the doctor's fault and they want to sue him. Is there some of that?
Yeah, I think that there are small kernels of truth in almost everything that you said, but I think it's also a little bit more complicated than that. One of the things that occurs when you're dealing with patients and talking to patients is the physician's usually in a position of knowledge, and they may be aware of 3 or 4 or a half a dozen things that may be effective therapies. But when they speak with patients, it's very hard to give them a list of 5 or 6 or a dozen things that are treatment options. And very often they're picking between the 2 or 3 things that are likely to benefit. So that's why it may be perceived as, an all or none or an extreme option. One of the things that makes those choices so difficult, both for the physicians and for the patients, is something that you hinted to earlier, which are the goals of care. And that is directly related to the idea of approaching death and dying as well. So very often when physicians speak with patients, it's not clear to them what does the patient actually want. And what really are they expecting? Are they expecting a full return to health and happiness? Are they expecting relief of pain and suffering? Or perhaps other goals. Maybe they would like to live for another 2 or 3 months to like in the springtime, one of the things that we see is people would like to make it to graduation to see their grandchild or great-grandchild survive. So there are many things that go into that conversation about these are your treatment choices and these are your options. And while it may seem like it gets reduced to something very simple, there tends to be a lot of different factors that go into it that are a lot of them are based in medicine, but a lot of them are related to the goals of the patients and trying to understand, well, what is it that we're trying to accomplish here? Or it may be dealing with things like the fear of death or the fear of dying that is lurking underneath. And sometimes patients may not be ready to hear, I'm sorry, but there might not be any treatment for you.
And Amanda, in addition, following on with what he's saying, isn't there just a variety of huge drugs that these people can be taking that changes their normal mind process? I mean, they're not probably in their best mental state, clearly, if they're suffering an illness. And there's tons of confusion that you can see especially in hospice. Haven't you seen that over the years?
I see it from time to time, and certainly no one is at their best in terms of their mental capacity and their decision making when they're physically ill, a lot of times emotionally exhausted, a lot of spiritual concerns at the end of life. So decision making can be difficult, but I think with good advanced care planning before someone gets ill, we can be guided, and the surrogate decision makers do have a bit of a roadmap in terms of understanding what somebody wants before they get that ill. I think one of the things that we talk about in hospice and palliative care is a concept called the surplus of trust. So we have this idea that patients think when a treatment course is no longer working for them and won't be effective and might make them worse, that their doctor will come to them and sit down and tell them that this is no longer working and we need to change gears. But meanwhile, the physician thinks that when the patient isn't doing well and has had enough, he or she will come to the doctor and say, this isn't working, I've had enough, I need to do something different. And so the patient is waiting for the doctor to say this isn't working, and the doctor is waiting for the patient to say I can't do this anymore, and meanwhile the conversation doesn't get had. And I see a lot of assumptions. You know, when I meet with patients and families, sometimes I'm the first person who's asked them, what are you hoping for? And a lot of times it's very realistic. I'm hoping that I won't die in pain. I'm hoping to see my son or my daughter who lives out of state. You know, very seldom do I hear, I'm hoping for the miracle cure, or I'm hoping that my mother walks out of here. So I think people tend to know when they're not doing well. And I hear it a lot, even in the hospice house in the very last hours and days, where people say, I thought 2 weeks ago that my grandmother was dying, but nobody would talk about it with me, and we were scared to bring it up.
And certainly there's a huge amount of emotion and upheaval that's going with the family too. And you know, with an ill person in the room, they not want to talk about it, correct?
Well, that can be. I guess my experience has been that most people are open to talking about it if it's done in a compassionate way, in a very honest way, in a way that honors the desire for knowledge, but tempers it with that sense that the physician won't abandon the patient. You know, no one wants to hear there's nothing more that can be done, and to be honest, there's always more that can be done. The question is, do you want more done to you, or do you want more done for you? And that's where the conversation is crucial. But those conversations take time. They take a team approach, and they don't reimburse as well as ordering another lab test or ordering a consult from a psychiatrist or someone else. So I think that's where maybe we have a bit of a dilemma, in that what we need to help keep costs contained and to make sure patients and families get what they want at end of life, it just isn't paid for. And not everybody, you know, you can't just assume that the homeless person on the street is going to get top of the line Mayo level care when he stumbles and gets hit by a truck because he's drinking too much, right? I mean, not everybody can get that level of care. It's just plain and simple. I think in America we like to think that everybody has access to the best care. I think the reality is that we do ration health care. We just have not done it equitably. We haven't done it in a way that's sustainable cost-wise. We haven't done it in a way that leaves people happy with the dying experience and the death event, and that needs to change.
Well, how would we ever know if anybody's happy with dying, since we've never been able to talk to anybody after the events happen?
No, but you can talk to people as they go through the process. And the dying process can be one that can actually be a very positive experience for patients and families. It is a part of life, just like the birth event, right? We can't talk to an infant about what being born is like, but we can look at an infant and know if the infant's in pain or if the infant is afraid. You know, an infant who's separated from the mother without that family support. And in the same way, we know when a dying person is comfortable, and that experience is reflected through the family. And ultimately, it's the family and the friends and the caregivers who are left behind. And all too often, I hear from them, if we had only known that hospice care was available, we would have done it a lot sooner. You know, no one wants to look back on someone's final days or final months and feel that that person was traumatized by things that were done to them.
David?
May I ask a
Yeah.
question? I'm encouraged by what I'm hearing from you, which is that at least among the patients and their family members who you see in hospice, there's a lot of frankness about the fact of death and a willingness and an ability to face the kinds of hard questions that come when someone is deciding how they want to die. But Karl, I wanted to ask you if it's different in the hospital situation where the emphasis may be more curative than palliative.
Sure. I think that in the hospital setting, the biggest difference between that and the hospice setting is that very often the prognosis is not certain. That in many cases the patients are coming into the hospital with an acute illness, and the general expectation is that it came on suddenly and it's going to go away suddenly. And it's the exception to the rule that you would have a very old patient who's visibly frail and obviously failing even to an untrained medical eye. Those tend not to be the patients that we see in our ICUs, in particular where we have this issue of spending a lot of money at the end of life. What we tend to see are people who were doing relatively well and they develop a pneumonia, for example. Or they were doing relatively well and maybe the illness crept up on them. They had a cancer and they were getting some chemotherapy and suddenly now they have a pneumonia. And, you know, doctor, I understood that I was going to be cured from this cancer, and now, you know, I'm in the hospital and the next thing you know, you're in the ICU. And so there's a lot less predictability for inpatient medicine. And one of the things that we see is that the conversation tends to evolve over time, so that what became part of a goal to be cured of the pneumonia or to be cured of some complication becomes a journey towards death. I think that one of the things that you said before is that it does involve a lot of the discussions with the survivors and with the families. And one of the things that we see very often in the ICU is that the way that the family and the patient move together through the process of their acute illness really is a driver of satisfaction, and it really is a driver of how they remember the death experience. And the things that we think are important are communication about goals, our communication about the sense of, well, you can't abandon me, or please don't abandon me, or please make sure that I stay comfortable. And a good relationship with a care team, I think those really drive, you know, even in the acute setting, what could be, you know, a good death. But when those things aren't there, when there is difficult communication, when the goals are not clear, so if recovery and survival is no longer a goal or no longer medically possible, what then? When those conversations don't occur is when we see those things, particularly with the survivors of the trauma or even PTSD, as they watch their loved ones go through the process of dying.
And I think we've all seen family members and patients with very unrealistic expectations. You know, the things that they are hoping for are things that medically we're just not able to offer at this stage. And that can be really hard when someone is making a decision to do something that medically we as physicians might think is very inappropriate for them.
And isn't there a certain element where some families are just not going to want to try and make a positive thing out of it? They're kind of in self-denial that this person who's always been their Rock of Gibraltar, their dad, their grandparent, or somebody like that, they can't go through the world without them, and that they're always going to be there, and they're not accepting of it, even trying to make it a positive event.
Certainly. I think that one of the things that it's really important for us not to make very many assumptions about are the cultural background and the cultural beliefs of the families and the patients that we're taking care of. So in some cultures and in some families, the loved one in the intensive care unit in the hospital is the leader of their family. It's their patriarch or their matriarch, and saying, no, please don't start that treatment, or no, please don't go towards life support on a breathing machine, would constitute abandonment. in their eyes, and so they would never make that recommendation, even if it was clear that the survival wasn't going to be possible. And some of those differences may be cultural, and those are things that we do have to be sensitive to in the discussion about death and dying, is that just because we view things in one way, it doesn't mean that a person from a different culture or a different family background may view it entirely differently, or they may feel compelled to continue on with the treatment because culturally those are their values and those are their beliefs.
And in fact, I mean, today, this morning on this show, we're talking about, you know, the cost of dying in America, but in fact, and we have some very fine facilities, but in fact, we aren't anywhere near the top of the world's countries in living long. I mean, Scandinavian countries and others are much better than us, and you can't say that their care is any more advanced or better than ours, is it?
I think in many cases the answer is no. If you want to measure things like life expectancy from birth to death, we look at other metrics or markers like infant mortality and judge an entire system that way. So yeah, those are one way to look at it. But you know, one of the things that I'm particularly interested in is the idea of value in healthcare. And the conundrum or the thought that I try to think about is, it relates to a patient that I saw right when I got out of training, which was a 34-year-old woman who was coughing through her pregnancy, and finally gave birth and decided to get that cough looked at. And it turns out she had widely metastatic cancer, which is cancer that had spread throughout her body. And the question that she asked was, well, you know, can I breastfeed while I'm getting chemotherapy? And so I thought about that quite a bit and really sort of began wondering, we could offer that woman chemotherapy knowing that she's not going to survive because she has widely spread cancer, and she may survive for a couple of extra weeks, and that chemotherapy may cost thousands and thousands of dollars. And that's one value to that person. And how would that value be different if that was suddenly the more typical or the more average 78-year-old or an 82-year-old who had been smoking all of their lives? Is the chemotherapy that costs exactly the same any more or less valuable to that patient? And I think that a lot of us would make some value judgments that, you know, maybe having a chance to spend time with your young infant would be a very valuable thing. But I'm not sure I want to make that decision about it's less valuable for the 78-year-old or the 82-year-old. I don't think that as a physician that's really within my domain. But also those are tensions that we have at the societal level of what are we willing to pay for and for whom. And right now, we don't have very strict limits on that. I do think there is some rationing that happens, and it may be because of bias.
And isn't there some rationing of that in, of course we could do another show on this, but it's going to come in Obamacare and then in what insurance companies approve?
Well, that was actually something that was announced just yesterday, January 26th,
Yes.
is that the Department of Health and Human Services actually released an announcement that they're moving toward value-based purchasing rather than paying almost like a per diem, you know, for each individual test, treatment, consultation, physician visit. Now, what that will look like for healthcare, I think, is anyone's guess. We don't know. But I think it's a huge announcement and has a lot of implications. And it is hard as a physician because I think for myself, I'm very uncomfortable with saying I will do for one but not do for another based on age or based on gender or based on a perceived value that someone contributes to society. We're not comfortable doing that. But I think that as a payer, the government is a large payer of healthcare costs, and our percentage that we spend on healthcare costs as a country has done nothing but go up. And eventually, we have to make some difficult decisions about what will be provided, what won't be provided, and to whom those services will be offered.
Well, I believe there was a well-known national politician that said something about well, we've got to pass this bill so we'll know what's in it. So without getting into political, that might be the same thing that you say on this value item. So it'll be interesting to see what happens on that. Now, is it possible that our medical science has evolved so that what their care is providing is unnecessarily delaying the dying process? I mean, we have a lot more tools in our bag now than we did 10, 20, 30 years ago.
So I don't know that it's necessarily that the technology is, costing too much. I think that one of the other ways of viewing that question is our ability as a healthcare system, is our ability as physicians and our knowledge as patients, has that kept up with the pace of technology? So when we have life-sustaining technologies that are new and very expensive, have the discussions and has the ability of physicians and patients kept pace so that the decisions that they make together are the best possible decisions. And I'm not sure that it has. When physicians talk about death and dying, very often it's in a very medical way. It's a medicalized event in life. But I think that in many cases, death is actually it's a family thing. It's a personal thing. It is an emotional and a relationship event, and it's not just a medical event. And so I wonder if really the problem is not necessarily that science has gotten out of control, or that the technology and the ventilators and the dialysis machines have just gotten so good that we're keeping people alive who are essentially dead. I really wonder if the problem is the discussions about who should be on the ventilators and who should be on the dialysis machines. I'm not sure that those have kept pace.
Okay. Well, we've got a couple minutes left in the program, so would you like to start us off with any final comments or thoughts on this, David?
Sure, I'd be happy to. It seems that we've come close to talking about the politics of this problem, but we haven't quite dived into it. But that is a real part of the problem, it seems to me. Before we were talking about the two main players in making these decisions, the patient and the physician. But it seems to me that for patients who are relying on government programs to pay for their medical care, the state is also a player in making these decisions. And this is why the announcement that you mentioned just a moment ago is so important. Identifying this third party only makes the problem more complicated, and from an ethical perspective, it's doubly complicated, because the ethical lens that the state brings to making these kinds of decisions, I think, is different from the lens that individuals make. I think individuals tend to approach the issue of death and end-of-life care from a personal point of view.
Okay. Well, David, you managed to make up for your lack of talking earlier, and you sucked away all the rest of the time.
Sorry, guys.
Thank you all.
That was a
Thank
good
you all for
summary.
joining this morning. And on behalf of the Interreligious Council of Cedar Rapids, Lynn County, go out and make our community a better place for all to live and play. Thank you for joining us.